Hello everyone. Today we'll be discussing about upper motor neuron lesions. It's a very important concept in neurology and physiotherapy as well. By the end of this video, you will understand what they are, their causes, the clinical features, and how we manage them. Yeah. Coming to the introduction, upper motor neuron lesions or else human lesions have a significant impact on voluntary movement and overall functions. They affect millions of people worldwide, and stroke is the leading cause. As rehabilitation professionals, it's crucial for us to understand them because they cause profound disability and reduce quality of life. Coming to the definition, anatomy, and pathway. So, what exactly is upper motor neuron lesion? It refers to the damage to the neural pathways that originate in the cerebral cortex or the brainstem. The key anatomical area is the primary cortex, and also called the precentral gyrus. So from here, signals descend through the corticospinal and corticobulbar tracts. These tracts eventually synapse with the lower motor neurons in the spinal cord, which then connects to the muscle. So when there is a lesion in this pathway, the communication between the brain and the muscle is disrupted. Here, coming to the causes and pathophysiology, the most common cause is stroke, accounting for about almost 80% of the cases. Other causes include traumatic brain injury, multiple sclerosis, spinal cord injuries, cerebral palsies, and brain tumors as well. So now in terms of pathophysiology, while descending inhibitory control from the cortex is lost, the spinal reflexes become more disinhibited. So this is why we see typical UMN signs such as spasticity and hyperreflexia. Over time, the cortical motor maps reorganize within themselves as well. So what is the clinical feature? So let's look at the main clinical features. The first one is spasticity. As we all know, this is a velocity dependent increase in muscle tone. So it is most common in leg extensors and in arm flexors as well. So the second thing is hyperreflexia, that is deep tendon reflexes or exaggerated, such as brisk knee jerk. Whereas the third one is the clonus, that is rhythmic involuntary contractions that are often seen in ankle region. Whereas weakness, especially in voluntary muscles, which may lead to problems like foot drop and stuffs like that. And the fifth, that is nothing but other signs like Babinski sign, and difficulty with fine motor skills such as buttoning a shirt might also happen in such cases. Coming to the diagnostic interventions, diagnosis of LMN lesion involves, the first thing is, as we all know, clinical examination of the reflexes. As I told before, hyperreflexia might be present, and the second one is checking upon the tone, in which where I previously informed that spasticity will be exhibited. The third one is strength, and the fourth one is sensation. The other tests like neuroimaging like MRI or CT is done to identify the lesion, whereas EMG is to differentiate between UMN and LMN lesions has also been done. And sometimes blood tests to rule out the systemic causes like multiple sclerosis might also be given to the patients. Coming to the physiotherapy assessment and goals. So in physiotherapy, our role is central, as we assess the spasticity using tools like modified Ashworth scale. Motor recovery can be tracked with the Figel-Meyer assessment. Balance is measured using the Beg balance scale, and the gait speed with the 10-meter walk test is also being done. And our goal is to focus on motor, that is improving the motor strength, functional control, functional independence, and preventing complications like contractures is also being done. Is also being done. Coming to the physiotherapy interventions, some key interventions like neurodevelopmental treatment, that is most commonly called as NDT, facilitating normal movement pattern, is also being advised. Constraint induced movement therapy, that is CIMT, encouraging use of the affected limb is also encouraged. Whereas the third one is functional electrical stimulation, particularly used for foot drop cases. Strength training is also given for targeting weakened muscles, and we also use stretching, splinting, and task specific training to manage spasticity and improve mobility is also being done. This is nothing but assistive devices and orthosis that is given to the patient to help to overcome the disease, that is AFO, walkers, canes, wheelchairs, and hand split